A warm welcome to all of you to this important public health challenge. It's probably one of the most important public health challenges of our time. How can we reduce the risk of dementia? Dementia is not only a growing medical issue, it is a societal challenge that affects families, communities, and healthcare systems across the world. But the good news is that we know more than ever before about the factors that influence brain health over a lifetime. From cardiovascular health and physical activity to early detection and social engagement and innovation in care. We have real opportunities to make a difference. This seminar brings together a variety of expertise to help us explore what works, where the gaps remain, and how we can translate knowledge into action. And with that, I would like to invite our keynote speaker, is Wilhelmina Hoffman, who is the principal at the Siliviahemmet Foundation and director in the Swedish Dementia Centre. Please, Wilhelmina, the stage is yours for approximately 15 minutes. You will listen to Wilhelmina.
Approximately, yeah. Thank you. Nice to see you all. We are all working for brain health. I'm a geriatrician from birth, I used to say, because I started very, very young in the care sector, only with persons with dementia. And I also performed a different type of research about dementia. And I had the opportunity to work together with one of our most famous professors in the world today, Professor Mia Kivipalto. We were here in this little area of Stockholm, really, sitting in the same corridor. She was doing her brilliant research, how to prevent dementia or how to postpone cognitive decline. In the same corridor was another famous professor. We will also speak about him from the company BioArctic, Professor Lars Lamfelt. And he was studying an antibody that could be used as a therapy to prevent the decline of cognitive disease like Alzheimer. But what did I do? Well, I am leading the National Competence Centre for Dementia in Sweden, and we are funded by the government, and we are working closely with all different authorities, with researchers, with academia, and we are a hub in between patient organizations, people with dementia, and family members. So we are a hub in between, converting research into practical knowledge. But today I'm going to speak about dementia and prevention, and these figures are from the Alzheimer's Disease International. And we know it's a huge growth in people with dementia the coming decades. So from 2030 to 2050, there will be a 80% increase in cases of dementia if we have no cure, which we do not have at the moment. And the cost, we heard about the cost, they are tremendous. $1.3 trillion US. You know, a trillion, it's a millions, you know, it's so many zeros behind that. And the cost will raise. This is not only the thing about dementia, of course. It's about suffering for persons with dementia, it's about the family, it's about knowledge in the care and social care system. How can we work and prevent all those problems coming with the disease? And it's not, dementia is not one disease, it's an umbrella term for about 100 different diseases that can affect the brain, so that you have dementia, trauma, etc. Just to example, here in Sweden, we have 150,000 people living with dementia at the moment, and of them 2/3 are living at home in their own apartments or villas. And we also have 2/3 with Alzheimer's disease, the most common of those 100 different types of dementia. And every year we have 20 to 25 new cases, and it will be a lot more in 2050. And the cost is 81.6 billion Swedish crowns. It's a huge amount of money, and it's more than the cost for cancer care, for example. Well, what can we do? It's about prevention. And here is Professor Mia Kivipalto, outstanding researcher from a little street over here in Stockholm. But she worked together with Karolinska Institute and the Finnish organization to try to find how can we see, what can we do to prevent cognitive decline before having dementia, or even how can you prevent decline when you have a dementia disease. And that's also very important. So she and her team created this model called FINGER. And you can see here from the institutions behind, it's Karolinska and it's the Finnish Institute for Health and Welfare. And she's also head here for FINGER Brain Health Institute. And from our perspective, from the National Competence Center, we cannot do anything by ourselves, but we can do it together with the researchers. How can we try to convert the knowledge into practical use for people, the public, in the civil society, persons with dementia, family members, as well as tools for people working in healthcare and the social care sector. But she's a role model. Well, what can we say about the modifiable risk factors? She introduced this FINGER model, the 5 lifestyle factors that could be modifiable already in 2015, and that was published in Lancet. And from that time, there has been more and more research about other risk factors that can affect the lifespan, or what can we do during from birth till, well, the last part of our life. So we have 40 now risk factors, modifiable, and if we can modify them, the risk is down with 45%, and that's a lot. So we can say hearing loss is one of them. Visual loss is a new from last year. Brain trauma, high blood pressure, we heard about that before. High cholesterol, LDL cholesterol, that's a new one from 2024. Diabetes, depression. And I think on that area, it's for the healthcare to look upon. What can we do in the healthcare system about that? In the middle part here, social isolation, physical activity, or inactivity, of course, smoking, alcohol, obesity. It's also for healthcare, social care, but also for the civil society, of course. How can we handle this together? And it's about the educational level. And that's from the early stage of life. It's important for the kids to get education, possibility to do that. And another thing is about air pollution. So these are the newly risk factors that published by the Lancet Commission 2024. It started directly, but
did you know
enjoy
that it is possible to prevent memory problems and reduce the risk of cognitive decline and dementia? Research shows that there are things you can do to positively impact your brain health, both now and in the future. The FINGER model shows how you can prevent memory problems and improve your brain health through specific lifestyle measures. We will take a closer look at 5 lifestyle areas, which we call FINGERs. These are linked to the health and functionality of our memory and brain. The 5 FINGERs are healthy food, physical activity, mental stimulation, social activities, and control of cardiovascular values, which concern our heart and blood vessels. Because what is good for our heart is also good for our brain. All of these FINGERs are equally important, and each FINGER individually makes a difference to our overall health and to our brain health. So taking care of just 1 or 2 FINGERs is, of course, a good thing. But it is when you take care of all 5 FINGERs at the same time that you can achieve an even better effect, according to research. And that is what the finger model is all about. That you address several lifestyle areas, in other words, all 5 fingers, at the same time. You will learn more about the 5 fingers and will receive concrete tips on what you can do and how in relation to each finger for the benefit of your brain. The good thing is that it is never too early nor too late to start changing your lifestyle towards better brain health.
Okay. So what we are doing, we have done this together with Miyake Vipelto and her Finger Brain Health Institute. So there is this education, free of charge web education now spreading all over the country, used by family supporters, used by nurses, etc. I think we are trying to reach the public here with this, but it's used by the many people working in the care and healthcare sector. We also have a little brochure here, a little easy written, not to make this too difficult to adapt to lifestyle changes. It must be, like I think that Pernilla said, it must be a little bit fun too. So not a pressure on you. So this little code here, you can reach the Swedish Dementia Centre. We have 16 free of charge web-based education programs. We have a lot of materials. We have a little library where you can find different information and ideas about dementia and how to keep yourself as healthy as possible. So with this, I will give back the word to you, Anders.
Thank you, Wilhelmina. I think a big round of applause for Wilhelmina. Please, Wilhelmina, you can have a seat and you will join us for the panel discussions. Now I would like to invite 3 more panelists on stage. They will give their perspectives on how to increase dementia, also given the presentation from Wilhelmina. We have Elisabeth Dupont, who is the regional manager for Europe from the International Diabetes Federation. Please have a seat next to Wilhelmina. Then we have Sophie Millar, who is the EU Policy and Advocacy Manager for Cardiovascular Health for the European Society of Cardiology. Please, next to Elisabeth. And finally, last but not least, Sven Jonsson, who is the president of the Swedish Kidney Organization at Stockholm, Gotland. They will all have a few minutes, 4 to 5 minutes, to give their views on this important topic, and then after that we will have a panel discussion with all included. So please, Elisabeth, I hand over to you to start, please.
Thank you. Thank you very much. And thank you to the organizers and to Pernilla specifically for inviting the diabetes community to be present here. I represent the International Diabetes Federation, the European office. So we have 73 national diabetes associations and we are present in 45 countries. You'll know more about the association if you want to, and I'm happy to talk about what I'm doing. I'm very passionate about my work. And to be honest, I initially didn't know that I was supposed to be talking about diabetes and dementia. Maybe I didn't, listen carefully enough, but I'm very, very pleased to be here because there are so many reasons why it's so important to talk about diabetes and dementia. I will only go through 3 of the reasons. The first one is that the figures are staggering. The link between diabetes and dementia is really, really significant. You have about 60% of people living with diabetes who are at high risk of developing dementia. You have about 1.5 people living with diabetes who will develop Alzheimer's disease, 2.5 more likely to develop vascular disease, vascular dementia. And also we know that people living with diabetes, they usually will develop dementia, between 3 to 5 years earlier than people not living with diabetes. So there is really room for improvement and work. The second reason why I feel it's important to talk about this topic is that among all the complications of diabetes, and you have cardiovascular, kidney disease, liver disease, the one that scares people the most is dementia. And it's also the one they know the least about. So it's very important to talk about it. And then the last reason is, I think, why we are here today. It's because it's possible to act. You said it. There are ways of preventing. And you even listed diabetes as one of the modifiable risk factors for dementia. So that's why we feel this is so important. So the link between diabetes and dementia is very clearly established right now. Diabetes is a chronic metabolic disease in which the body doesn't regulate properly the level of glucose in the blood, either because the pancreas doesn't produce any insulin or because the body doesn't use the insulin properly. And we know that the brain uses glucose as one of the main sources of energy. So if you have low or high level of glucose in the blood, this has an impact on the brain, and it has also long-term contribution to neurodegenerative diseases. We also know, and I think you mentioned it, that diabetes damages small brain vessels, which also creates vascular dementia. So we have heard the link between diabetes and dementia, but we also know that dementia and diabetes have a bidirectional relationship. People living with dementia have much more difficulties in managing their diabetes, and that has a huge impact on the evolution of diabetes. Diabetes relies a lot on self-management, so meaning that people living with diabetes, they have a lot of medication to take, they will check their blood glucose on a regular basis, they will have to calculate their food intake to see what kind of and what level of insulin they have to inject. Obviously, when you have even the very first sign of dementia, this is becoming very difficult. People living in diabetes also use a lot of the technology. Again, something which becomes quite difficult as soon as you have some kind of cognitive impairment. So we have established the link between, why it's a dual burden, and we feel that it's extremely important to make sure that we address this considerably. There are the biological mechanisms that are common, but there are also the social determinants mechanisms that are common. We know that both diabetes and dementia are more common in lower socioeconomic environment, people who have, and I think someone also mentioned it today, people who have less high level of education, less access to health enabling environment. So there is a real need for policymakers to address both, the healthcare approach, but also the societal one. So what we think about as an International Diabetes Federation, we feel that it's very important to make sure that we address and improve the management of diabetes across the life course to reduce these modifiable risk factors. We feel that it's also important to address the inequities between access to healthcare. We feel that it's important to integrate the diagnosis of dementia into the diabetes care. And ultimately, we feel it's important for family and caregivers to be able to support better people living with dementia and diabetes.
Thank you, Elisabeth. We come back to that in the panel discussion later. So we invite Sophie from the European Society of Cardiology's point of view. Can you reflect on this sort of challenge that we're facing with how to decrease the risk for dementia?
Yes, absolutely. Thank you so much to Pernilla and the organizers for the invitation as well. As mentioned, I'm Sophie. I work as EU Policy and Advocacy Manager at the European Society of Cardiology. We are a non-profit medical society representing healthcare professionals in the broad field of cardiovascular health. But a little disclaimer, I'm not a healthcare professional myself, but I work, as mentioned, in public affairs, so based in Brussels and trying to engage with the EU institutions. And it was really interesting morning so far, and I think it also gave me more material that I will use in future for my advocacy, because also preparing for this panel, actually realizing and understanding how strong this link is between heart health and brain health is, I admit, fairly new to me actually. I've been working for EC for 2 years, but this is a really important argument we maybe don't bring enough into our conversations and into our advocacy so far. And as it said very nicely in the video already, what is good for the heart is good for the brain. So I think this is really clear. And what we see now, we have from the European Commission this EU Safe Hearts Plan. In a way, because it's addressing many of these modifiable risk factors, it can be seen partly also an EU Safe Brains plan, because there's a very strong focus on prevention. And I think the link here between cardiovascular health, brain health, is all about prevention, particularly in those midlife years. And some of the initiatives that will come thanks to this EU plan, in particular, I think around early detection and earlier diagnosis, will then lead to better management and better outcomes and better brain health as well. And I think, mentioning more material for advocacy going forward, it's important to bring these two worlds together, because there's dual benefits to tackling what we talk about as cardiovascular risk factors. But if you are managing correctly your blood pressure, managing lipid control, stopping smoking, you're going to see dual benefits for the heart and for the brain. So I think also thanks to the organizers for putting these topics and these perspectives together. It's very beneficial.
Thank you, Sophie. Then we turn to you, Sven, from the Swedish Kidney Organization. Please,
Thank you
your
very much.
perspectives on this.
Before I talk about, do you hear me? No, it might come some through the microphone.
Yes,
Yeah,
yes.
here it is. Before I talk about the relationship between chronic kidney disease and dementia, I will explain a little bit about chronic kidney disease, CKD. The prevalence for it is about 850 million in the world, and that is 1.5 times more than diabetic, and it's 20 times more than cancer. In Sweden, there is approximately 10% that have chronic kidney disease, but they don't know about it because it's called the silent disease. CKD do have 5 different stages. When you come to stage 4 or late 3, you might have the symptoms. That's why it's called the silent disease. When you come to stage 5, you need treatment, like dialysis at the hospital or dialysis at home, or transplantation of the kidney to survive. So it's a serious disease. But is it possible to detect chronic kidney disease in the earlier stage? Yes, it is. And with the most simple thing, actually, to target the blood pressure. And if you have higher blood pressure, ask the physician at the primary care center to take kidney tests, for example, blood test and urine test. Then you can discover it in an early stage. What are the symptoms for the patient when CKD begin? The most common maybe is the fatigue and long-term fatigue, and this is affecting the life quality for the patient. It's also sometimes affect the cognitive function. It also affect the mental health in the perspective of becoming anxious and depression. And then we talk about mental health in that area. And sorry to say, we are not targeting that problem enough today. When it's then come to CKD and dementia, it's shown from scientific reports that if you are elderly and you're in stage 4 and 5, and you have a high progress of the disease within a year or so in that time frame, then you have a much higher risk for dementia. Also, there is a publication showing that of a dementia patient, 30 to 40% of those who have dementia do have CKD or kidney dysfunction. So there is a clear relationship between chronic kidney disease and dementia. But if it's a correlation only or it's a causability, that's not for sure. And this, we need more research to target this. I will stop there and take the discussion further on.
Thank you, Sven. I think we kick off the sort of panel discussion. We already started, but we kick it off once more. Turning to you, Wilhelmina, listening to your fellow experts, but from slightly different therapeutic areas. What's your spontaneous comments to what you hear?
Well, I think being a geriatrician, I met all the patients with the cardiovascular problem in kidney disease and of course diabetes. So I think that we should lift this up because it's affecting the aging person. It's not the young person affected at the moment. So I think working together is so important to reduce the blood pressure and check up for the diabetic risk factors, of course, about obesity, etc., and malnutrition in different ways. Also, to really coordinate the cardiovascular and the brain vascular. I mean, the vascular system is in our whole body. And we have to take care of I think it's a beautiful formulation, the crown jewel of the evolution, the brain. So working together we must do that. And I think that when we work from the Swedish Dementia Centre, even if there are several experts in our group, we work to spread information in a real basic level. And we know that to change habits, models, routines in the healthcare system takes a long time. It's about, I got the figures, about 18 years from a new model, a new routine to be implemented in the healthcare system. So we have to make this faster, and then we have to work together in different ways.
Wilhelmina, you said in your presentation, early on in your presentation, that you are funded by the Swedish government.
Yes.
That also brings a very, very political dimension to all of this, which could be quite technical. And as Sven was alluded to, a lot of things that we don't know. We don't know about causability or coloration. How do you experience that your discussions with the politicians are going on in that sense? Because this is quite complicated. If you come from a political aspect, I mean, this is really complicated. So how are your opinions being met or received?
Well,
no?
at first the government is financing the National Board of Health and Welfare, yes, who is financing us. Yeah. So we have in some ways direct contact with ministers discussing about dementia strategies, etc. But we mainly work with the National Board of Health and Welfare and other authorities, really. But I think that today our government knows about that prevention must be the thing you have to put money in. And I know that it's been a large amount of money now going, it's 50 million Swedish crowns, like 5 million euros, to the National Board of Health and Welfare to promote the finger model all over Sweden. And that's a lot of money. But we have to work more together because we have the same goal, having people living in their best life, even if they have a chronic disease. But you can live a good life even with dementia. And if you have like diabetes and dementia, if you have this good structure, help with checking the blood, the values of the blood, the glucose values, and having the right treatment, I mean, life can be good, but it must be pressure on the healthcare system here, and also working together with the social care, and also information to the family members, and the person themselves must know before you have the...
May I react?
Of course, of course.
No, I think you are obviously totally right, and I just wanted to refer to a publication that came out just last week from the Lancet Diabetes and Endocrinology. I think it's very timely, where they were showing that for the first time, the main mortality in people living with diabetes in some European countries is no longer cardiovascular disease, because of all the improvement in the management of cardiovascular disease, but cancer or dementia. So I think the question now is, if we want to look at the criteria for quality of management of diabetes care, it's no longer only how long a person will live, but how well they will live. And that's exactly what you were mentioning about the quality of life of the people living with both conditions, chronic conditions. Yeah.
Sophie, do you want to also comment from the European perspective? What you also listen to what Elisabeth said about sort of...
Thanks. Maybe, a couple of comments, of course, in total agreement as well. But maybe a thought that I had when we're thinking, we all agree prevention is so keen. It's going to benefit no matter which NCD we are talking about. The hard thing is that we also heard a bit this morning of getting prevention on the political agenda. Politicians, they're also, human, and they have their life experiences. They may agree, but as a political policy, it seems really, and it has been really, really hard to get it on the agenda. And now it was mentioned earlier as well. There's lots of spending on defense, military preparedness. In Brussels, we hear competitiveness all the time. So we need to try and make it relevant in the current political context, and using arguments about how, in order to have any competitive population, they need to be healthy first before they can do anything else. So it's just about framing it in the right context of today's world.
I think it's exactly sort of the same discussions everywhere, even in the Nordics around, if you were listening to the previous seminar, also talk about this productivity thing, about giving competitiveness, and so Europe losing out to other parts of the world, both in R&D wise and also when it comes to other parts of the Sven, from your perspective, from the Swedish Kidney Organization, you talked a lot about this sort of silent disease and also the strong link, even though we don't know whether it's causability or not, between kidney disease and dementia. Would you like to reflect on where are you on this, and also from an advocacy perspective, what are you doing?
First of all, I'd like to say thanks for organizing this discussion, because we don't talk so much about CKD and dementia. We might talk about, as I said, depression and other mental issues, but it's needed to create awareness about the correlation between different diseases, chronic diseases, and dementia. And there is comorbidity when it comes to diabetic and to cardiovascular diseases. And therefore, you're talking about prevention, and that is important, really important. But to be able to do prevention, you need to have an early detection of the disease, especially when we talk about CKD. And for that, we addressing to the primary care, because there is a national program for chronic kidney disease, but the primary care doesn't use it as much as they should. It should be used in daily business. It should be, doesn't matter if the patient come to the clinical reception and have high blood pressure or having heart cardiovascular problems or diabetic, they should track if there is a kidney problem as well. And if we can detect this earlier, then we can hinder the progress of, so it doesn't go to late stage. So we can do the recommendation of lifestyle changes. Of course, then we have 4 of the fingers of this. And if we do this working together with diabetic and cardiovascular associations as well, we can also take the 5th finger in this. And we will have the 14th of April, we will talk about all these 3 perspectives, diabetic, cardiovascular, and kidney problems in a conference that is open. So I think it's important that we actually encourage, and I think it's important also that the government help the primary care, so they will be able to follow these national programs, so we can detect early, so we can hinder the progress, and then we can also have a better and higher quality of life for the patient, and we can prolong the start of dialysis, and that is important for our perspective, from our perspective.
Thanks. Wilhelmina, from your perspective, do you agree with Sven on the need to invest in primary care and the sort of abilities in primary care to early detection, regardless whether
yes,
it's...
I of course I do, and I think you go even earlier stages, because in the education system now, we need a change really, because we need to know about all those things in the school for doctors, nurses, physiotherapists, everyone. Yeah. When I started my med training in the 80s, it was a half a day about the old brain, a half a day, and that dementia was like half an hour that day. So I started to educate and be a teacher about the aging brain and dementia, and tried to find, and it was a lot of research coming up at that time. So still several of those universities, they do not provide the students with the right know-how, because I think it starts there if we go to the primary care system later on, because they need to have health conversation today that's ordered by the government, and they don't have time, they don't have the tools. What can they say to people? It must be built in from the beginning. So that's my... I think to change the education system, we need to do that 10 years ago.
I will put an open question to the panel, but you can also think whether you have any questions or comments you want to make, because we'll have time for that. And I hope we have a mic in the audience. So please, given what we're talking about now, primary care, is it actually possible to sort of have this sort of knowledge level in primary care, given the sort of extremely quick development of all the knowledge there is, all the research, all this? I mean, is it actually, do we need to rethink the way we not only train, but also provide healthcare in the sort of more local setting? Is it possible?
Yes.
Yes, yeah, good.
Of course.
Yes, Sven.
Yes, absolutely, it's possible. I mean, we are in the digital era, but more and more workload is put on the primary care. So it's important that we have some kind of e-consultations from the specialist, from the hospitals, to back up and support the primary care. If we don't build in that in the system, it will not work. But with a good e-consultation or e-supporting system to the primary care, I think it's doable, absolutely.
Elisabeth and Sophie, do you agree? Is it a viable way forward to invest more in both knowledge-wise and also resource-wise in primary care in order to?
I think it's putting a lot of pressure on the primary care system, because, as you were saying, they are already overramped, but they are the entry gate for most of the chronic conditions, so they are essential. But maybe we could also think about increasing the role of the nurses, of the community workers, maybe even the pharmacists. I think maybe trying to share the workload where people have, easier access, maybe a way forward.
You're reading my mind because I've read other professionals. I wrote on my papers. That's perfect. Sophie, do you want to comment on that as well?
Yeah, I think just shortly, there must exist some nice country examples that I don't know of from the top of my head. But in the UK, they brought in a physician associate program, and agree with Elisabeth, maximizing other healthcare professionals, but knowing that we have a healthcare workforce crisis throughout Europe. But yeah, we need to think of some solutions.
We have a question from the audience. Please, Bo.
Thank you. First, I must say that I'm extremely pleased that there is now such a focus on prevention of dementia, because this has not been the case. I remember a G7 meeting in London 11 years ago, and it was just a focus from industry and from research and drugs to treat the disease, and it was almost not mentioned with the prevention. I'm very pleased that this is now coming up, because this is so very, very important. And also to see the larger role here of the primary care, really, and I think, as you said, to increase accessibility. I have experienced difficulties to just have a blood pressure checked, and this took 30 minutes to discuss that. I could not take my blood pressure here because I was not registered here, and now you can just go in and you can do it yourself, and there is no need of any health professional at all. It's just freely available, really. So I think there is so much to do in terms of easy access. And also I'm very pleased to see this opening now with cardiovascular health and cardiovascular risk factors, and the recognition that cardiovascular is not only heart, it's also the heart and the brain and the cognition and the stroke, and that this is seen together. This is such an important game changer in our concepts, really. So I'm very pleased with the discussions that I hear, and also from the kidney disease that from we see as clinicians, when it has progressed to severe chronic kidney failure, then it's so difficult to treat and to give the drugs and to use anticoagulants and everything. So prevention is so important, really. Thank you very much.
Thank you.
We have one question or comment from the back, and then we have Desiree in green in the middle. So we start at the back, and then we'll try to round this off, because you need your lunch break. So that's why. So please.
Hello, good morning. My name is Magdalena Dakar, and I'm Chief Executive Officer of FH Europe Foundation. It's a network of patient organizations for people living with inherited lipid disorders. So when I saw your presentation, and you did refer to specifically cholesterol, obviously it's very relevant, because we represent about 90 million people in Europe alone. And when I say Europe, I specifically mean European Union here, versus 150 million in wider Europe, who have elevated lipids, cholesterol, as well as elevated lipoprotein A. And I've been looking up quickly publications around correlation between dementia and Lp(a). Anyway, my point here is twofold. One, we live in the world, as everyone has observed, there is increased appetite to promote prevention, primary prevention, or maybe lifelong prevention. And I think at the same time, all of us are using terms: silent disease, invisible disease, kidney, CVD, and so on and so forth. I think we need to start helping policymakers, politicians, and ministries of finance funding those programs, that there is no disease more or less important than the other, because they're coexisting. And having any activities to prevent dementia can help prevent other conditions, and vice versa. I think our community needs to be strategically smart about leveraging synergies, trying to identify individuals' pockets of interest in politicians. Like that, we will be competing against each other, rather than demonstrating this life course of one leads to the other, and acting early to elevate or diminish one in long term translates into something else. That said, I wanted to pick up on a point that Sophie mentioned. Politicians very often look at short-term gains and low-hanging fruit. We know that with the Safe Hearts plan right now, there is an ambition, at least in the EU, to tackle CVD, and by 2030 to bring down premature CVD by 25%. it's mostly impossible unless we target people at high risk, which means that strategy by itself is doomed for failure because it's not targeting people across their life span, starting early. And everything that you brought within the finger, which I love because it's very easy to remember, is about healthy habits, eating, being active, socializing, da-da-da-da-da-da. And those are fundamentals of healthy living for any of our disease areas. So my final statement is, I think it's time for us to be smart, collaborate enough and show synergies so that politicians finally see that there is no such thing as short-term gain. It needs to be translated into marathon of health for Europeans, Swedes, and so forth. Thank you.
Thank you. You just hand over the mic to the lady in green in front of you. So we have a final comment from Desiree, and then we'll just try to round this up. Thank you. Just
Thank you
please.
so much, and very interesting to hear about all these combinations concerning dementia. And I have a question. I will be later on as a patient, actually, in one of the seminars, but I was former also politician. So I just wonder, asking you, Wilhelmina, I know that you have like a Siliviahemmet certifying different, I think mostly the communes use it, how to get to understand. And I think this sounds like you also could have it in the healthcare sector, in the emergency room or something, to understand how the combination with other healthcare patients, how it can be combined with prevention. And could you say something about your certification system?
Yes, and from the Foundation Silviahemmet, first we trained people in the academic sector, nurses, doctors, etc. And Her Majesty Queen Silvia, her mother had dementia, so she's behind us. She's our she provides the titles to those professionals, but then we saw that they couldn't change one by one where they work, so we started to certify whole care units, everyone like in a hospital, everyone working in the cleaning room or with the food, nurses, doctors, etc. So if they succeed this education, the training, they can be certified just for a couple of years. And then we have another model from the Swedish Dementia Centre called Star Branded, and that is a little bit the same, but it's from the national guidelines, etc. So it's also a model that we have like 2,000 STAR instructors all over Sweden at the moment training. And if you are STAR branded, have a STAR branded unit, you have just for 1 year, you have to show that you are working like you said you were going to work. And that includes all the person-centered care, blah, blah, everything. And all professionals are included. But we are looking now for go more into the healthcare system with a model that can be used, and that so that they can show, because it's a lot of psychology also here. Of course, it's fantastic with Her Majesty to have the brand from her. Yeah. Yes, and also the title from her, of course. But to have that on your unit, it's like, so I think it's a very, very good idea here. I bring it back.
Yeah. Thank you. We're a final round of comments from the panel, and then we have to close this seminar. We could go on for hours, I think. But if we meet in 1 year for the next future days here in Stockholm, what would you have like to see for progress, Sven, or change, or?
I hope that the government have made a decision that blood pressure monitors should go under free use for each and everyone, so everyone has it at home, so we can early detect this. Because if we early detect it, then we have the possibility to make a real change. This is something new I just came up with now, but I think it's possible.
That's good.
Thanks.
A very good result from this panel discussion.
Yeah.
You now have a new proposal to bring forward to the election campaign. Sophie, please, what would you like to see change in 1 year or progress in 1 year?
I would say something along the lines of that we are louder together 1 year ahead than we are today, that we all recognize the power of strengthening each other's arguments, that it builds the best policy case for politicians.
Which is very much in line with the comments made before from the audience as well. Elisabeth, what's your wish list for next year?
I would hope that maybe the implementation at national level of the Safe Hearts plan would go in a very person-centered approach and having this integration of all these non-chronic conditions being seen as not being separate but being part of the same system and needing to be addressed, as I think Magdalena said, as Sophie said, you know, in collaboration and with understanding of that what matters is the person.
Perfect, thank you. And finally, Wilhelmina, you both have the first say and the last say.
Okay.
What's your wishes for
Well,
next
I
year?
say collaborations and trust in each other. I think that's it.
And that puts a very nice end to this seminar. Thank you so much for joining us. Looking forward to meet you later on this afternoon. And now I think we actually are for a lunch break, aren't we, Matthias? We have a lunch break now. An applause for the panel. Thank you so much.
Nice meeting. Thanks.